Can you recognize who is she? Okay. What happened to her? So how was she diagnosed? Is basically singer or actress? Both singer and actress. So celebrities can have disease. It's not that the celebrities cannot have the diseases. These diseases, the autoimmune diseases, are common in the females, and even the celebrities are not spared. Even your social status, your wealth status, and if you are a VIP, it's not that you will not have the disease. So all of a sudden, anybody can have a disease. He or she may be at its top notch at the of his or her career, and suddenly there is a diagnosis that you have got certain disease. She has got a renal transplantation also because of the involvement of kidneys. She had renal failure, and she had undergone renal transplantation. But this is after transplantation. So her friend donated her a kidney. So she is having. So celebrities can have diseases. SLE is a disease which is more common in females. Most of the autoimmune diseases are more common in females. What is SLE? SLE is a progressive chronic autoimmune disease, and that results from the inflammation and tissue damage. So it's an inflammatory disease. Just like rheumatoid arthritis, there is inflammation in the joints. In SLE, as the name suggests, the patient is having systemic involvement, systemic lupus erythematosus. What is lupus? Does the patient look like wolf? Rashes? So the lupus word has come from wolf, and as if the patient has been attacked by a wolf over the face. So erythematous rashes are there. So because of the erythema that is there on the face. And the patient can have varied presentation. Patient can have mild disease, the patient can have this minor organ involvement, or the patient can have the major organ involvement or the life-threatening disease. Some patients may have only involvement of the skin, and the mucocutaneous involvement can be there. Some patients can have musculoskeletal involvement and the major organ involvement, like there can be involvement of the kidneys, lungs. So in the kidneys, the patient can have nephritis and can even have the renal failure. Like this, the celebrity has undergone the renal transplantation. It's highly heterogeneous disease. Even the male patients can also have this SLE. And as the name suggests, it's a systemic disease. It's not a local disease. So any part of the body can be affected, any organ can be affected, like the lungs, kidneys, eyes, skin, the vessels, even can have vasculitis. So nervous system, peripheral nervous system, central nervous system, all these systems can be involved, and if not treated properly, if not diagnosed properly, it can be fatal. So there are few celebrities who can have this, who have got this lupus. Historical aspects. The term lupus, the term was used to describe the erosive skin lesions evocative of wolf's bite. So that's why the term lupus has come from. Systemic lupus erythematosus. Erythematosus you all know. Erythema is there. So lupus was first recognized as a systemic disease with visceral manifestations by Kaposi in 1837 to 902. This is the this lifetime of the Kaposi. Systemic form was further established by Osler, and this description of the false positive test for syphilis in SLE was also described. And there is interchangeable word that is used is the connective tissue disorder. So connective tissue disorder is a group of diseases which are clubbed under the certain autoimmune disease clubbed under this connective tissue disorder. It's a group of disorders like SLE is one of them, systemic sclerosis, SLE, mixed connective tissue disorders, undifferentiated connective tissue disorders. These all are grouped under connective tissue disorders. So natural history. So the etiology is exactly not clear as in other autoimmune diseases, though the patient is genetically susceptible. A genetically susceptible host is there, and upon which there are certain environmental factors. It may be certain exposure to smoking, certain aniline dyes, certain like insecticides, or certain unknown factors may be there. UV light may be responsible. So when the combination of these environmental factor is there, and the patient is genetically susceptible. It's not that everybody with that exposure will have the SLE. So the individuals who are genetically susceptible will develop the disease, and in the disease also the patient can have the pre-clinical period in which the patient will not have any symptoms. In these studies, it has been shown that the autoantibodies or the antibodies can be present decades before the clinical development of SLE. It's not only in SLE but in the other autoimmune disease also. The antibodies can be positive decades before the development of the clinical manifestations. So this they have got these samples from the blood banks and the other sources, like they have the preserved samples of those patients. And when they developed the SLE, they have checked the autoantibodies that these were there years before the development of the clinical manifestations of SLE. So preclinical period, the autoantibodies may be positive, and clinically the patient will have manifestations, and then the patients can have comorbidities. With time, the patients can have the complications also. So in the preclinical period, then we have in the clinical period, the patient is having the inflammation and involvement of the organs, and then there can be flare-ups. These diseases, the patient is having the patient may be in remission, then again the patient can have flare-ups, then again in remission. So depending on the, sometimes it is unknown which patient is going to flare up, who is going into flares. So even when the patient is controlled on the drugs, he is on treatment, the patient can have flares. And some patients who are not on regular treatment may be in remission. So it's not predictable that which patient will go into flare or not. The patients are usually on the corticosteroids and the other immune modulating and immunosuppressive drugs. So these patients are prone for certain infections. The patients are prone for secondary infections. Because these patients are on corticosteroids, the patient can have complications of use of long-term corticosteroids. The patient can have secondary infections like the bacterial infection, tubercular infection, viral infections. These patients are prone for the secondary infections. And the disease itself, the patient is prone for, there is certain higher chances of having malignancies like lymphomas. So pathogenesis, environmental factors, genetic factors, the patient is genetically susceptible, and there is abnormal immune response. So immune cells are involved. There may be defective suppressive network. The immune suppression phenomena that occurs naturally may be defective. So autoimmunity is there. Patients can have abnormal immune response to antigens, dendritic cells, B cells, T cells may be involved, and the complement factors may also be involved. There is a complex interplay between these the immune cells and the cytokines. So certain cytokines and the complements can also be involved. So autoantibody immune complexes can be detected. So these complexes are thought to be responsible for the organ damage. This can have manifestations over the skin, kidneys and the other organs. The patient can have skin rash, can have nephritis, can have arthritis. The patient can have hematological involvement in the form of, the patients can have thrombocytopenia. The patients can have leukopenia. The patients can have anemia. The patients can have CNS disorder. The patients can have involvement of the CNS in the form of CNS vasculitis. The patients can have carditis. There can be pericardial effusion. Serositis can be there. Then pleural effusion can be there. Involvement of the lungs can be there in the form of interstitial lung disease. Then there can be secondary antiphospholipid antibody syndrome. There may be this thrombosis, recurrent thrombosis can be there, recurrent abortions can be there, especially in the second trimester. So all these abnormalities can be there because of these antibodies. And damage-wise, the patients can land up into renal failure, requiring hemodialysis support, and may even require the renal transplantation. The patients can have atherosclerosis. In the almost all the autoimmune diseases, there is a risk of premature atherosclerosis because it's an inflammatory process, and because of that there is a premature atherosclerosis. Nowadays, in the pathogenesis of atherosclerosis, it has been shown that the inflammation is there. So CRP values are higher in the patients who have got this premature atherosclerosis. These patients can have premature acute myocardial infarctions. The patients can have CVAs, cerebrovascular accidents can be there. The patients can have pulmonary fibrosis because of the involvement of the lungs. The patient can have interstitial lung disease. And then the patient can have damage because of the therapies like the corticosteroids and the immunosuppressive drugs that are being used for its treatment. The male-female ratio is around 8 or 9:1. So 85% are women. It's not that it's not there in males. It's not that it can be there in males, but in males, if it occurs, it's of a severe variety. Ratio peaks in the reproductive years. Then the ethnicity, you know that it's much more common in the African Americans, Asians, white men, it's lesser. And in India especially, its prevalence is more in the northeastern states. In northeastern Mediterranean countries, it's much more common. In northeastern states and Mediterranean countries, the prevalence is high. The patients can have, almost half of the patients can develop the organ-threatening disease, like there can be involvement of the kidneys, lungs, and 50% of the patients can have organ-threatening diseases. So diagnosis. How do we diagnose SLE? You have got a textbook picture, you might have seen a case, like the patient is having typical rash over the face from a distance, or you can make a spot diagnosis, like this patient may be having SLE. So these are basically the classification criteria. These are not diagnostic criteria. The diagnosis is clinical. So diagnosis is always clinical. The patient may not be having all the manifestations to start with initially. I'll give you an example. The patient, a patient came here with high-grade fever. The young female, she was completely all right, nothing was there. She was having the high-grade fever. She visited certain clinicians over here in Haldwani. She was basically from this Motaldu area. And she visited this certain private clinics, and she has received various courses of antibiotics because she was having high-grade fever. So she has received anti-typhoid treatment and the various antibiotic courses, but she was not relieved. ESR and CRP was high. At times these patients are started on empirical anti-tubercular treatment also, because the ESR and CRP's high, fever is not responding to antibiotics, and fever is more than 3 or 4 weeks. These patients at times are given anti-tubercular treatment empirically, like the fever may be there because fever is not responding. It's not responding to antibiotics, so it may be, patient may be having the anti-tubercular treatment. It's the common scenario in our country where the tuberculosis is very prevalent. So she was received various courses of antibiotics and she was admitted here. Last she came here. The ANA test was done. She was not having florid manifestations of SLE. typical manifestations were not there. She was having high-grade fever. She was having certain joint pain. Typical rash was not there when she first visited our hospital, and she was investigated, and her ESR and CRP was high, and she was not having any renal involvement. The urine examination, there was no proteinuria, no RBCs. So anti-nuclear antibody test was done. It was highly significant. So she was diagnosed as a patient of SLE, and she was put on certain treatment. And after that, she lost to follow-up. She took treatment. She become all right. And after a few days, she lost to follow-up. And again, she landed up in emergency department. She landed up in emergency department with altered sensorium. She was altered sensorium. She was having breathlessness. She was in bad shape. She was admitted through casualty in the ward. So she had the... What has happened to her now? She was diagnosed with SLE. She was on treatment. This time she presented in emergency with altered sensorium, breathlessness, high-grade fever. What happened was, because it's a chronic disease, it was a flare. It was a flare because she took treatment for a few days, and after that she thought that she is all right, so she stopped the treatment. So it's your duty to convince the patient it's a chronic disease and you have to take long-term treatment for it. The patient is not ready, like the young male and females, they are not actually ready for long-term treatment. They thought that I am completely all right. Why should I take the treatment? So she was admitted, she was in flare, and at that time we have to go for aggressive treatment, because at that time it's a life-threatening disease. The patient is having serositis, pericardial effusion is there, she is having involvement of the CNS, so aggressive involvement is there. She was admitted, and then the attendants have taken her to Delhi. So in Delhi private hospital she was admitted. She was referred for AIMS New Delhi, but she got admitted at a private hospital, and she got the treatment for flare. She got the steroid pulses. So we give when the flare up is there, to counteract that we give the methylprednisolone, in high dose methylprednisolone as a pulse therapy. IV infusion is given for 3 to 5 days, and she was also having involvement of the CNS, so she was given rituximab infusions. What is rituximab? Anti-CD20, that is the B-cell therapy. So anti-CD20 antibodies rituximab was given, and after that she became completely all right. After having such a serious episode, organ-threatening this episode, now she is having proper treatment. After few days, she came here. The rituximab infusion was given here also. Second dose was given here because a fortnightly dose is given. Second dose is given fortnightly. Second dose was given here, and she was on treatment. Later on, the treatment was tapered off. She was off steroids. She was off all the treatment. She got married, and she got pregnant after marriage, and now she is completely all right. But at times the flare-ups are there. So you have to convince the patient that there can be flare-up of the diseases. So these are the classification criteria. All the criteria may not be there in a single patient at a given point of time. The patient can have skin rashes to start with. The patient may not have skin rashes. The patient can have fever or the non-specific manifestations. So diagnosis is clinical, and it's not that you can make the diagnosis in a single visit. Though the proper diagnosis may take time, may take few OPD visits or the admissions for proper diagnosis. So for the classification criteria for a research purpose, these are the criteria, like the patient can have butterfly rash, discoid rash, then photosensitivity can be there, oral ulcerations can be there, the patients can have arthritis, serositis, the patient can have involvement of the kidneys in the form of nephritis, the patient can have neurological disorder, Then in the laboratory criteria, the most important screening test is the anti-nuclear antibodies. Anti-nuclear antibodies is positive. Then there can be other antibodies like anti-double-stranded DNA antibodies. Then the positive, the anti-SM antibodies can be there. It can be associated with antiphospholipid antibodies, and the lupus anticoagulant can also be there. So ANA is a screening test, and most of the patients, more than 95% of the patients are ANA positive. Less than 5% may be negative, but it's a dictum that all the patients of SLE will have ANA positivity. But the condition is should be done by which method? There is a method for doing the test also. It's important when you order the test, you should know which test by which method. ANA is also done by ELISA method, EIA method, which is the gold standard method for doing the anti-nuclear antibodies test. It's the immunofluorescent. It requires a immunofluorescent microscopy. So anti-nuclear antibody test should be ordered by IF, immunofluorescent method. So they give the titer and the pattern also. So this is the how they look under the immunofluorescent microscope. Can you see the fluorescence? Here you can see the fluorescence. So there can be different patterns. Rim pattern or peripheral pattern can be there. Solid or homogeneous pattern, speckled or nuclear pattern can be there. Like this is the homogeneous pattern. Homogeneous in the A figure, first figure. This is a homogeneous pattern. Then the patient can have speckled pattern. Then the patient can have nuclear dots. This is a nuclear pattern. Then the patient can have nucleolar, then centromere, centromere pattern can be there, then cytoplasmic pattern can be there. So various patterns are there. So you should know that it should be ordered by immunofluorescent method. The fluorescence pattern is important and the titer is also important. How much is the end titer? How much is the initial titer? So it should not be ordered by ELISA method. At times we have seen the reports that it's being ordered by ELISA method because it's available. It should be ideally be ordered by IF method, immunofluorescent method. Then the common signs and symptoms of lupus, the patient can have this painful or swollen joints and the muscle pain and unexplained fever. Like the patient can present with pyrexia or fever of unknown origin. The patient can have skin rashes, especially in sun exposed areas over the neck, back, over the hands, over the face. The patient can have chest pain during deep breathing. The patient can have serositis, this pleuritis can be there. There can be unusual loss of hair. Renal's phenomena can be there. Photosensitivity can be there. Edema in legs and edema around the eyes can be there. Recurrent oral ulcerations can be there. It's a typical phenomena. There can be swollen glands. Parotids can be swollen, lymph nodes can be there. Extreme fatigue can be there. So it's a very important this aspect, fatigue. The patient feels, if a young female comes to you in OPD, she is having fever, extreme fatigue and the similar findings are there. You should think of autoimmune disease. So in the mucocutaneous lesions, it's not that always the malar rash will be there. Discoid rash can be there, mucous ulcers, alopecia, subacute cutaneous lupus can be there. This is acute presentation. Then cutaneous vasculitis can be there, skin rashes, this is palpable type of purpura can be there. Bullous lupus paniculitis. Paniculitis is the inflammation of the fat. So inflammation of the fat or the paniculitis, it may be tender. The typical skin rash over the malar eminence and the bridge of the nose, and there is a sparing of nasolabial fold. You can notice there is a sparing of nasolabial folds. Female patient, and photosensitivity is there. The rash can be transient. At times when you examine the patient, rash may not be there. So DDF malar rash. The rash can be there in dermatomyositis. The rash can be there in the rosacea. You can notice that there is involvement of the nasolabial folds here. So its rash looks similar to SLE. Perioral dermatitis, then seborrheic dermatitis, atopic dermatitis, tinea over the face. So other features should be there. When you see the rash, you should take proper history. What are the other features? So it's not that this typical rash is there, it's only in SLE. And these patients can have discoid lupus, then scarring can be there, scarring alopecia can be there. These 10% of the discoid lupus patients can develop the SLE. These coin-shaped scaly plaques can be there. And usually the permanent type of this alopecia or hair loss is there over the scalp. Reynolds phenomena, dysautonomia, vasomotor instability can be there. The patient can have mucocutaneous involvement, then there can be musculoskeletal involvement. Musculoskeletal involvement, the patients can have arthralgia. Arthralgia means the patient complains that he or she is having joint pain. Arthralgia means it is a symptom. The patient is complaining that she is having joint pain. So it's a common presenting feature. The patient may be having associated early morning stiffness, which is suggestive of that the joint pain is of the inflammatory nature. So usually symmetrical, it can involve the hand joints and the knees. The patients can have arthritis. Arthritis is a sign. The patient is having typical inflammatory features, clinical features. So how to differentiate between the rheumatoid arthritis and SLE? Hand joints can be involved in rheumatoid arthritis and SLE. The other features of SLE will be there. The high-grade fever is unusual in rheumatoid arthritis. Because of the inflammation, the low-grade fever can be there in rheumatoid arthritis. But usually high-grade fever is not there in rheumatoid arthritis unless the patient is having associated infection or underlying other condition. The patient can have myositis, inflammation of the muscles can be there. Then can be inflammatory tendinitis can be there, myalgias. Then this osteoporosis can be there. These patients usually do not develop the deformities, unlike the rheumatoid arthritis. If the deformities are there, these are the correctable deformities. In rheumatoid arthritis, it's permanent deformities. So Jacquard arthritis is described in SLE. So it's a correctable type of deformities are there. The patients can have serositis. The patient can have pleuritis, pericardial effusion can be there, pericarditis can be there. So symptoms will have, the patient will have chest pain on deep breathing or when lying flat. So when fluid accumulates, the patient can also complain of the shortness of breath, like I have given you example with the patient admitted here. The patients can have interstitial lung disease also. There can be shrinking lung syndrome. Shrinking lung syndrome means the volume of the lung decreases. There is a diaphragmatic weakness. Because of the diaphragmatic weakness, the inspiratory effort is not proper and the lung volume decreases. Hematological abnormalities, the patient can have anemia, thrombocytopenia. The patient can have lymphopenia, neutropenia. Even usually in the viral infections also the patient presents with fever, like the dengue fever the patient is having. Likewise, there is an epidemic of dengue fever, the patient will have thrombocytopenia. Leukopenia is usually there in viral infections and patient may be already anemic. So pancytopenia picture can also be there in these cases. So you should be cautious. So differential diagnosis of SLE. The patient can have in the differential diagnosis like the rheumatoid arthritis. The typical skin rash and all these features will not be there. And there is a typical involvement of hand joints and the other joints which may be similar to SLE. But typical skin rash and the deformities can be there in rheumatoid arthritis. But permanent deformities will not be there in SLE. Scleroderma, you know that the patient can have the Reynolds phenomena. There is mainly involvement of the skin, and the skin becomes thick, and it's difficult to pinch the skin. That is called as sclerodactyly. When it's difficult, when we try to pinch the skin over the digits, we are not able to catch hold of the skin. That is called as sclerodactyly because of the thickening. Sclero means thickening of the skin is scleroderma, and sclerodactyly. Then the patient can have this myositis, like the patient of dermatomyositis can have typical skin rashes. Along with that, the patient will have involvement of the muscles, weakness of the muscles. Usually the proximal muscles will be weak. The patients can have vasculitis. So vasculitis can be primary vasculitis, or vasculitis can also be there associated with the SLE. SLE can also cause the vasculitis. Then spondarthropathies or spondarthritis, there is involvement of the spine, basically inflammatory arthritis involving the spine. In the spondyloarthritis group, we have got the Reiter's disease, we have got the psoriatic arthritis, and prototype example is ankylosing spondylitis. So in the Reiter's disease or the reactive arthritis, the patient can have skin rashes, and usually the lower limb large joints are involved along with the involvement of the spine. The spine is not involved in SLE. In rheumatoid arthritis also, spine is not involved except for the cervical spine. The patients can have inflammatory bowel disorder like the ulcerative colitis, can have inflammatory joint disease. The patient will have prominent features of involvement of the GI system. The patient can have bloody diarrhea. Then Behçet's disease, there is a recurrent mucosal ulcerations. There can be genital ulcerations, there can be oral ulcerations. The patient can have fever. The other features may be there. In sarcoidosis usually can involve the skin, like lupus pernio is there. The patients can have involvement of the lungs in the form of, there can be hilar adenopathy, and there can be involvement of the lung parenchyma in the form the patients can have a picture similar to interstitial lung disease. And in the sarcoidosis, there can be joint involvement. Typically, which joints are involved in sarcoidosis typically? There is a prominent typical involvement of the ankle joints. So if bilateral ankle joints are involved and you have gotten this hilar adenopathy on chest X-ray, you should think of sarcoidosis, and it responds very well to the treatment. The patients can have thyroiditis, then polymyalgia rheumatica can be there, then undifferentiated connective tissue disorders. Undifferentiated connective tissue disorders is a group of disorders which cannot be classified or diagnosed as a particular disease, may be having the overlapping features. Then the infections like tuberculosis, Lyme disease. Tuberculosis is there in the differential diagnosis because the tuberculosis can have varied presentation. Bacterial endocarditis, HIV, CMV, Epstein-Barr virus. The patients of fibromyalgia can have non-specific features. Pain here and there, particular points are there which are tender to touch. So particular points are there. Patient may be having stiffness, more common in females. Skin rashes are usually not there. Fever is usually not there. Low-grade fever may be there. Then various allergies can cause skin rashes. Then neurological disorders like myasthenia gravis can have muscle weakness. There can be ptosis. Then multiple sclerosis can have involvement of the CNS. Then malignancies. At times the presentation may be there because it's a paraneoplastic syndrome. There may be certain malignancy, like a female came with joint pain and she was having involvement of the hand joints. She was around 50 years of age and she was having joint pain. All the investigations were done, rheumatoid factor, anti-CCP, everything was negative, but she was having inflammation of the joints. It was typical inflammation of the joint was there. She was put on an anti-inflammatory treatment, she was on treatment, and later it was found that she was having CA breast. So carcinoma of breast can, or other malignancies, these arthritis can be in paraneoplastic syndrome or paraneoplastic symptoms. So serial follow-up is very important for these patients. Then there can be drug-induced lupus, like certain drugs like isoniazid, very commonly used as anti-tubercular treatment, procainamide, quinidine, then methyl dopa, chlorpromazine. So drug-induced lupus can be there. Then in drug-induced lupus, like the anti-TNF antibodies, like infliximab, and these drugs can also have the drug-induced lupus. There may not be florid presentation of lupus, but antibodies may be especially anti-histone antibodies may be positive, ANA may be positive, and anti-histone antibodies may be positive in drug-induced lupus. Then psychiatric disorders may be in the differential diagnosis because there is a neuropsychiatric involvement also in SLE. So diagnosis is clinical. It's always clinical. The tests are supportive. At times you think that the patient may be having some features of autoimmune disease. There may be underlying connective tissue disorders. You have ruled out other infections and the other conditions. And at times you see that the ANA is borderline positive, like 1:80 or 1:100. 1:100 or 1:80 titer is borderline. Patient may be having or may not be having. So in these patients you should be very cautious. If titer is highly significant, like 1:320 or more, then you think that it goes in favor of autoimmune diseases, connective tissue disorders. But if it's borderline, then it may be false positive also. Because ANA positivity can be there in general population also. With increasing age, the incidence of having ANA positivity increases. Like 5% of the population can be falsely positive for ANA. And the chances of having ANA positivity normally increases with increasing age. So you should remember this. Then the other specific antibodies can be there, like anti-double stranded DNA, anti-SM antibodies, then anti-RNP, Rho, La, then anti-cardiolipin antibodies and anti-phospholipid antibodies can also be positive. And then for histological diagnosis, we can have the skin biopsy and the kidney biopsy, because patients can have this organ-threatening involvement of the kidneys, and we can have the kidney biopsy. Kidney biopsy is done in patients who are having heavy proteinuria, and the patients are having other features. So kidney biopsy is done to look for, to grade for the which is the grade of or class of the lupus nephritis. We classify it according to the classification, which grade or which class of lupus is this. So we have to give the treatment according to that. So coming to the useful test in SLE, routine screening of all the patients, we do the CBC. Then urine analysis is important. In the urine, it's a very important test for these patients, because in the urine we look for proteinuria, and apart from the proteinuria you look for, because these patients are having glomerulonephritis if the kidney is involved. So for glomerulonephritis, the finding will be there. Which finding will be there in the urine examination? RBCs, dysmorphic RBCs. Dysmorphic RBCs may be there. Then the RBCs may be there. Then the RBC cast may be there. So these are suggestive of the patient may be having the underlying glomerulonephritis. So casts are important. So these are called as active sediments in urine. We say it as active sediments, urine examination for active sediments. So you have to specify, you have to contact your pathologist that this is a patient of connective tissue disorder or SLE. So please report it accordingly. So we want to look for active sediment. Active sediment means if the patient is having cast or dysmorphic RBCs, so they will pay more attention to these cells. Then muscle enzymes may be increased if there is inflammation of the muscles. Then acute phase reactants like ESR and CRP are high. Chest X-ray, the patient may be having serositis, like pleural effusion can be there. Then on ECG, the patient can have low voltage complexes if the patient is having pericardial effusion. And ANA already we have discussed, it should be done by immunofluorescence method, and titer is important. And when the patient is having active SLE, anti-double stranded DNA titer will be high. So for anti-double stranded DNA, we go for ELISA test, and we want the value. How much is the value of the anti-double stranded DNA? In active lupus, if the CNS involvement or renal involvement is there, the patient will have increased anti-double stranded DNA. And what happens to complement levels? Complement level decreases when active nephritis is there. So because of the consumption, the C3 and C4 can be low. So if C3 is low, anti-double stranded DNA is high. At times it's difficult, like it's a known case of SLE or connective tissue disorder. The patient is having fever. So fever may be there because of the secondary infection or because of the flare. So it's difficult at times to diagnose whether it's a flare of the disease itself or it's because of the secondary infection. So if these tests are in favor, like anti-double stranded DNA is high, C3 is low, it goes in favor of the flare. Then the other tests which can be done, like the echocardiographic clotting test, then the ultrasonography can be done. Then one is the ANA, anti-nuclear antibody, other is the ENA. ENA is the extractable nuclear antigens. This is a costly test. ANA is for screening and ENA is, it's a costly test. We look for specific antibodies like anti-SM antibodies, anti-Rho, anti-La, because if the antiphospholipid antibody may be positive, and these patients, if having antiphospholipid antibody syndrome, if it's positive in mothers, there is a chances that the fetus may develop the complete heart block in utero. Then we have got antiphospholipid antibody panel, lupus anticoagulant, anticardiolipin antibodies, beta 2 microglobulin. Then we have got the specialized testing for certain particular circumstances, like the imaging can be there when there is involvement of this CNS involvement for MR can be done, and if we are suspecting this medium vessel vasculitis, along with that we can go for MR angiography or CT angiography. Electrical studies like EMG, EEG can be done, bone scan can be done, and various other antibodies tests can be done. So this is a case history, like 23-year-old woman, unremarkable history until 3 months ago, currently feels tired and achy and flu-like symptoms, heavier than usual periods. Physical examination, some fullness at the MCP joints, dull discomfort, take deep breaths, mild erythematous rash over the cheeks, and mild erythema over the face. She is under stress at work, poor sleep, lack of exercise. I've given a real example. One student from here in India, from I think nearby district, she went to USA as a student. She was a young female and she was having fever and the other features, and in the US it's difficult to get appointment of a specialized doctor. It takes weeks to months to get an appointment. So she was diagnosed with SLE over there and she was put on treatment, and ultimately she had flare. She could not get the treatment. It's a story of few months to years. She could not get the appointment properly, and she was basically neglected over there. Parents were not there, and she died over there without any treatment. It's around 5-6 years back. She died because she didn't get proper treatment for SLE, for her SLE flare even in US. So it's difficult. Like in India, you can think of, we got readily accessible specialists and the treatment is there. But in US, it's basically you have to go through a channel. You will first go to the hospital, then the nursing staff will see you, then doctor will see you, MBBS doctor will see you, then you will have appointment with MD, and then we will have appointment with a specialized. So it's a channel. You can go through that channel only. But I think in the emergencies, they might have bypassed. But she expired over there without treatment. Shown on laboratory findings. Normal blood chemistry, mild anemia was there, ferritin was low. Urine, she was having trace proteinuria, no cast or RBCs. ANA was positive, 1:160. So baseline, borderline is 1:80 or 1:100, and 1:40 or below is negative. ESR was 30, CRP slightly high. Rheumatoid factor was positive, complement was slightly decreased. Anti-SM, anti-double stranded DNA, anti-SSA, SSB, roll over negative. Chest X-ray, small right-sided pleural effusion. And urine protein creatinine ratio was negative. So she was having difficulty in breathing, skin rash was there. So malar rash was there, sun sensitivity was there, ANA was positive, she was having serositis in the form of pleural effusion, inflammatory arthritis was there because she was having involvement of the MCP joints, fullness was there. So classification criteria says that the 4 out of 11 if criteria are positive, including the ANA, it's positive. So it's for classification criteria. For diagnostic criteria, to start with, patient may not have all the features, but you have to start the patient on treatment according to your clinical diagnosis. So commonly used medications for SLE, we have got the NSAIDs to start with. If the patient is having mild involvement, then we have got the antimalarial drugs like the hydroxychloroquine. It's a dictum that hydroxychloroquine should be given to every patient of SLE, irrespective of the manifestations. It should be given to every patient of SLE. It is safe during pregnancy, it's safe during lactation. So it should be given because it's a disease of the young females. So childbearing age group females are there. So it's safe in pregnancy and lactation. The adverse effects, the patient can have certain GI disturbances. And long-term use, some patients can have over the skin. What can happen if long-term hydroxychloroquine use is there? The patients can have hyperpigmentation of the skin, darkening of the skin can be there, especially over the sun-exposed areas. Then corticosteroids. The dose of corticosteroids is different, and the indications are also different. So if mild manifestations are there, we usually use the low dose. And if life-threatening organ involvement is there, we give the high dose corticosteroids. Then we have got the monoclonal antibodies like belimumab or rituximab are used for its treatment depending on the organ involvement. Then we have got the immunosuppressants like cyclophosphamide, azathioprine, mycophenolate, mofetil are being used. Then for inflammation, pain, fever, simple NSAIDs. Then monoclonal antibody usually it works at the level of B cell because it's CD20 against the CD20. Then we have got immunosuppressive agents works on the B cell and T cells. Corticosteroids are strong. Suppresses the inflammation. Then hydroxychloroquine is thought to act on the T cells and the cytokines. Likewise, it was used in the treatment of COVID also, because there was inflammation. And it was thought that the hydroxychloroquine acts on the viral entry and viral replication in the COVID. So you have to first establish the diagnosis. At times, it happens that in remote areas, the patient dies of the disease without being diagnosed that she was having SLE, because the awareness is not there, and the other thing is these laboratory investigations are not available over there. Like ANA is not available, or through IF method, ANA may not be available over there. So the awareness of suspicion should be there. You should suspect at least a young female having rash, fever not responding. Why should a young female have pleural effusion? At times the patient can present simply with the pleural effusion. and at times it's these patients are put on antitubercular treatment, and even after putting these patients on antitubercular treatment, the patient is not responding. Then we think that this patient is not having tuberculosis, and then proper diagnosis is there. So you should be cautious that there is a possibility that pleural effusion may be there because of the SLE or connective tissue disorder. So suspicion should be there. The physicians at the periphery should be aware of the condition, they should suspect, and they can timely refer the patient to the higher centers. And the proper investigation should be done at time in the initial phase, so that the patient is put on treatment properly at time. Because later on, when the patient is already in renal failure, patient has already have end-stage renal disease, the only option you have left is with the renal transplantation. So you can diagnose the disease early so that the proper treatment can be started in due course of time, and patient may not develop the complications of end-stage renal disease. So we have to assess the severity and the organ involvement, if there is a major organ involvement or not, and physical measures in all the patients. For minor organ involvement like the skin involvement, patient P can be put on hydroxychloroquine, low-dose corticosteroids, and a steroid-sparing agent we can use the azathioprine methotrexate. For mucocutaneous or musculoskeletal involvement, this can be used. For major organ involvement, you should be more aggressive, like the B-cell antibodies are used, high-dose corticosteroids is used, then other treatments like cyclophosphamide pulses are used for SLE nephritis, active nephritis. Then counseling is important, patient's counseling regarding the disease, because it's a long-term disease. The patient has psychological aspects, the patient can go into depression. Like somebody is told that you have got this disease and it will be there for lifelong. So it's a depressing disease, so you should counsel the patient that with the treatment you will become completely alright. You have to take the long-term treatment. There is you can have your normal family left an issue. You can give examples that these are there and they are on treatment and they have completed their family. It's not that it's a disease which you will not complete your family. So you have to tell about medications, because certain medications are there which are not safe during pregnancy, and certain medications are there, alternatives are there which are safe during pregnancy. So the patient should be told about the medications, which medications are safe during pregnancy and which cannot be taken during pregnancy. Proper counseling should be done, and if required, the tissue diagnosis like tissue biopsies are taken usually when the proteinuria is more than 500 milligrams, and when the patient is having active sediment, we usually go for the renal biopsy. And if the patient is having classification or the grading is there, so grade 3 or grade 4, like we should be very cautious, very aggressive in the treatment. Like in our hospital, if patient's family is complete, we give the cyclophosphamide pulse. Cyclophosphamide 1 gram, this vial is there. The cost is around 100 rupees only. So you have to give monthly pulses, 6 pulses are there. The cost is only, that injection costs 100 rupees only. You have to give with pre-medication and proper hydration. It can cause infertility. If the family is not complete, we should be cautious. Otherwise, the other options, mycophenolate mofetil. Mycophenolate mofetil is costlier. The one tablet of 500 milligram costs around 50 rupees, 35 to 50 rupees, and the dose is 2 to 3 grams per day. So 4 or 6 tablets per day. So it's costly. Some patients may afford, or some patient may not tolerate the mycophenolate mofetil because of the GI disturbances. So because these patients are having photosensitivity, so avoidance of the sun and use of sunscreen is advised in these patients. Temperature monitoring is advised. Then occupational therapy, vocational rehabilitation, exercises, diet and vitamins, nutritious diet, and management of fatigue. All these are the aspects which the patient should be told about. Patient education programs, we can educate the patients regarding the disease. Then the patients can have the patients group. These days, when uncommon diseases are there, the patient make their own groups on social media and they discuss among themselves like which disease, which manifestation they are having, which treatment is going on. So they can discuss and they should be more confident about the disease, and one patient gives counseling to the other patient. So by group discussion, it's beneficial for all the members in the group. So they can clear their doubts and the physician can have their queries solved. See, dose of cyclophosphamide we usually give in these patients of active nephritis is the 15 milligram per kg body weight. So it comes around in a 50 or 60, around 750 to 1 grams. And what are the adverse effects of cyclophosphamide? The patients can have vomiting, the GI disturbances can be there. So usually we give the antiemetics as a pre-medication. We give antiemetic as pre-medication, dexamethasone as pre-medication, and we give the proper hydration to the patient to prevent the hemorrhagic cystitis. The patients can have hemorrhagic cystitis if hydration is not maintained. Mesna can be given, and even if you do not give Mesna proper, if you give the proper hydration to the patient, then we have hardly seen any patient with hemorrhagic cystitis. So hydration is very important. So any queries or questions regarding this? So that's all for. Thank you.